Connected by purpose, driven by passion. This is Children's Healthcare Canada's Spark Live webinar series.
Children's Healthcare Canada would like to thank the following Keystone funding partners for their ongoing contributions that support all of our programs and activities. The Stollery Children's Hospital Foundation, BC Children's Hospital Foundation, the Children's Hospital at London Health Sciences Centre, the Alberta Children's Hospital Foundation, the Children's Hospital of Eastern Ontario, and Holland Bloorview Kids Rehabilitation Hospital. We would also like to thank the organizations that provide funding for our knowledge translation activities, which includes this Spark Live webinar series, the Spark Conversations blog, and the Knowledge Exchange Network. To learn more about Children's Healthcare Canada, you can go to our website, follow us on Twitter or Facebook, or you can sign up for our weekly Spark newsletter at childrenshealthcarecanada.ca/email, where you will learn about upcoming events, read the latest posts from our blog, and other exciting news and events from across the child and youth healthcare community.
Hello everyone, and welcome to this special edition of Children's Healthcare Canada's Spark Live webinar series. I'm Paula Robeson, your host for the next hour. Spark Live is where we gather each week to curate, convene, and showcase excellence and innovation from across the child and youth healthcare community. And our goal is to spark conversation, ideas, and action. Since we're live, I want to remind everyone that while we don't take questions over the phone line, you all have the opportunity to type questions into the question box at any time. We'll check periodically for questions throughout the session and take them at the end. Please don't feel you need to wait until the end of the presentation before you start typing. Just go ahead, put them in as you think of them. We're delighted today to be joined by colleagues from our member organizations, Sunny Hill Health Centre for Children, Toronto Hospital for Sick Children in Toronto, and McMaster Children's Hospital for supporting families of children with medical complexity during COVID. For those of you on Twitter, please tag us at Child Health Can to any webinar-related tweets and share away. I would like to welcome our speakers for today. Audrey Lim is a pediatrician and medical lead for the Complex Care Program at McMaster Children's Hospital and associate professor at McMaster University. Dr. Reshma Amin is a staff respirologist at the Hospital for Sick Children, associate scientist and child health evaluative sciences at Sick Kids Research Institute, and an associate professor in the Department of Pediatrics at the University of Toronto. And Carolyn Chow is a nurse clinician at Sunny Hill Health Centre for Children. It's my pleasure to pass the mic to Audrey.
Okay. I'd like to thank the Children's Healthcare Canada for giving me this opportunity to present today, and as well as to organize this very important webinar. For the next 10 minutes or so, I would like to walk you through the world of children with medical complexity, pre-COVID, as well as during COVID time, and how our team is supporting these families, as well as to go through some future directions. So just taking a step back to reflect. As you know, a lot of our parents and caregivers for CMC, children with medical complexity, are very well trained. We train them to care for these children safely at home. We've done simulations with them, with acute life-threatening situations such as a blocked trach, accidental decannulation. They know what to do in terms of supporting these children at home. However, when pandemic struck in March, the world was shutting down. There is no simulation to prepare these families for COVID-19 pandemic, nor us. There is high anxiety and fear of the unknown in our children and families. In the last year or so, we did a qualitative study looking at the care of our children and families with children with medical complexity and technology dependency. There were 4 themes that emerged: the burden of care, home care nursing, finances, and social isolation. I would like to use these 4 themes to walk through with you the impact of COVID-19 has had on our family. First, the burden of care. Pre-COVID, there was already increased anxiety and stress caring for the children. This mom put it really well. She's always on edge, heightened state, And she feels like she's a new mom, but she has been going through this for the last 10 years, and it's exhausting and tiring. During COVID, it has put an extra strain on these families because they have to be extra vigilant to minimize the risk of exposure. And another mom has put it as huge anxiety right now in families with complex care parents, and they are looking to us as a team to help them. Next is home care nursing. Pre-COVID, there was a global shortage of home care nurses. This is even worse now in COVID times because some families have opted not to have nurses to minimize exposure risk, and some families are providing 24/7 care, which raise the concerns of sustainability and caregiver burnt out. Decisions that parents have to make during COVID for nurses is this a harm reduction approach, meaning screening nurses pre-shift, or total risk elimination approach, putting all nurses and community support on pause, knowing that this is not sustainable in the long run. This is a true struggle for a lot of our families. And one of our families has shared with us an algorithm that she has used looking at risk assessment of making decisions if the nurse should be working in the home or not, depending on if there is low risk environment or high risk. Next is financial impact. We all know that pre-COVID, a lot of our families struggle with finances. It takes about $7,000 to $8,000 in terms of medical supplies to send a child home. And on top of that, the everyday ongoing bills. During COVID, a lot of our families have chosen not to work in order to protect their child safely at home. On top of that, medication supplies only 1 month right now, and there's cost of other supplies that have increased. This has definitely added to the financial stresses of our families. Social isolation is next. Interestingly, a lot of our families feel that they already know what social isolation is like. Like this mom put it really well. Most of our families know the importance of hygiene and sterilization. They already self-isolate because they're wary of germs and stay days and weeks and months in hospital rooms. It is the world that's actually knowing what isolation is like right now. And however, during COVID, there is extra sense of anxiety and fear and isolation. This is one of our patients who's looking out of the window looking for his friend. So these are some poignant quotes that I have received from our families in the last few weeks. And it really spoke to me, especially this one. I thought you, the team, have forgotten about this. And then all these quotes, as you can read them, really speak to the fear, the anxiety, and the need for information and guidance from a complex care team. So next, what is our team doing right now to support these families? Through the quotes that we've learned from our families and hearing from them, I've divided them into 4 areas of focus: availability, accessibility, assurance, and advocacy. In terms of availability, we have what we call a who to call when list of contact information of our complex care team. They can reach us via email, cell phone, pager, or text messaging for some of our families. We've made ourselves very accessible, and as all of you have, we have turned our face-to-face clinic into a virtual clinic that started March 16th. Since then, we have seen about 80 children through our virtual clinic. The goal was really to keep them safe at home. We've also done urgent virtual clinics and teleconferences when there's a need. We have seen 2 patients in clinic in person just because we needed to do physical examination and blood work that can't be done through virtual clinic. For our virtual clinic, we use a clinic template. First of all, to review systems, and then we go through some of the COVID preparedness areas, such as medications and supplies, making sure that they have enough medications to last them through the pandemic, refills that needs to get done, And we check in with home care services to see if there's any decrease in nursing, community services, the screening of home care nurses and workers, as well as their supply of PPE. We touch base with the family as well to make sure that other family members are well, if there is any COVID swabs done, and how they're coping, especially with other siblings in the house because school is out. We also look into financial strains, cost of supplies, and some of our families who have problems getting groceries. We also know that some of them really need updated information. There's so much information out there in the media, and we really try our best to distill the information that is appropriate for our complex care population. And as you know, they're rigorous with hand washing and isolation. So that's something that we also try to reinforce, as well as social distancing that they have done very well with. Right? Next thing is assurance. As you know, a lot of our families are looking to us for information and guidance. Early on in the pandemic, we developed a COVID-19 preparedness infographic that was sent to our family members. It covers what is COVID-19, the signs and symptoms, preventative strategies, and ways to communicate with us, and also telling them that we've changed clinics to virtual clinics and how it's going to be booked. And this really has helped some of our families feel more reassured, and that communication is still ongoing between our team and the families. Our families also need constant reassurance as to when they need that they are okay, and that when they need to come in to emerge. As you know, a lot of our family members are avoiding coming to emerge as well as to the hospital. If they do need to come, we do remind them to let us know beforehand. We go through the process of coming to emerge, the screening process for COVID, and this also allows us to inform our emerge physician of the patients coming in, and we would give them a comprehensive care plan to give them the heads up. If admission is needed, we really try our best to do direct admit from home to our complex care ward if possible, and also to review AGMP precautions with our family. One important area is advocacy during COVID. We have written letters for our families to employers to allow parents to work from home, as well as some of our parents who needed to wear masks at work for safety reasons. And some of our families really have problems with supplies such as catheters and masks, and we're in the process of helping our families secure some of the PPE supplies. So thirdly is future direction. We are using this opportunity to study the impact of this pandemic on CMC, and also to develop a virtual quality improvement tool. When COVID-19 is over, we still feel that virtual clinic is one of the ways to conduct clinic, especially when our families, when they travel with many supplies and equipment. And I think virtual clinic still serves as a good way of running clinics, decreasing the burden of travel for our families. The development of a QI tool will measure 3 areas: satisfaction with healthcare team, satisfaction with virtual clinic, as well as COVID-19 specific information. This tool will be validated for you. The objective of this study as well is to measure quality of care through virtual clinic, as well as what are the barriers, because we don't want this to be an added financial stress to our family if they have increased cost of internet in order to do virtual clinic with us. We are also looking into health impact of caring for these children through 4 validated promise scales measuring fatigue, sleep, anxiety, and global health. And we hope to collect some healthcare utilization data on image visits, admissions, and COVID infection. Some areas of improvement. We are developing a parent or a peer support group. We've just started the process of doing needs assessment of our families, both in families who have children with trach, home mechanical ventilation, as well as the medically complex, to help identify gaps and how our complex care can be helpful to these families. And we really want to emerge better from this pandemic as a complex care team in the care and support of our children and families with complexity. Thank you very much.
Hi, good afternoon, everybody. Just following along on the theme that Audrey has so nicely laid out for us this afternoon. So I am really thrilled to have been invited to talk about a project that, unlike Audrey's work that's well under its way, this is a project that we're hoping to launch next week. So I'm going to be talking about the long-term in-home ventilation engagement program, otherwise known as the LIVE program. Home mechanical ventilation represents one of really the most advanced specialized therapies that are offered at the home to individuals. And in Ontario, there's many ICUs set up in the homes of these children and adults using ventilation. And there are over 5,000 people in the province that use ventilation at home currently. These individuals are medically fragile, they're frequent users of the healthcare system, and as you've heard from Dr. Lim already, they really have a high associated burden of care. So we know from Ontario data that for individuals who go home with a ventilator for the first time, that 50% of them have a visit to the emergency department, and over 1/3 of those individuals require hospitalization. So they use the healthcare system frequently and intensely. Virtual care, as we've all come to know a lot about with COVID-19, really can be defined as any interaction between patients and members within the circle of care that occurs remotely. And virtual care really is an opportunity for children with medical complexity and children using long-term ventilation for us to be able to overcome the constraints of distance, cost, and time. So virtual care really is an ideal option for many patients because clinic follow-up is challenging. Many of our patients come from quite a distance to travel to the hospitals. Travel is expensive, and travel also can be potentially unsafe. Many families leave the clinic visits, having to sort of suction the children at ends because they've been behind in their airway clearance. They haven't had access to their typical technology during clinic visits to the hospital. Secondly, these individuals also move across the healthcare system quite frequently, from acute care to rehab to home care to acute care, and there's multiple transitions and handovers along the way. Additionally, there's often a lack of timely access to respiratory professionals who are specialized in long-term ventilation at that moment when they're needed the most. So virtual care really does provide an opportunity to bring the right people with the right expertise into the homes of medically fragile individuals. And with that in mind, that sort of paved the way for the LIVE project, which I'm going to speak about. And I want to just acknowledge that really the inspiration for this project came from Cristiano, who you can see in that picture to the right there, and his mother, Francine Buchanan. So Francine is an incredible individual, a real inspiration to us all. She is a parent of a child who's now 7 years old, who's invasively ventilated, and she's also completing her PhD in health informatics. 2 years ago, she said to me, Reshma, I really think that our patients would benefit from an e-health app or platform, and she had seen something when she had been on at an e-health conference. Fast forward 1 year later, and we were successfully funded to launch an e-health platform randomized control trial to children and adults being initiated on ventilation in Ontario. But then step in COVID-19, and now that trial's on hold. However, what we've learned from COVID-19 is that it's really more important now than it ever was before to keep our patients safe at home. And so our team thought that the resources that we had developed in terms of developing this eHealth platform, really now would be the right time to try and get this out to all of the children and adults in the province who use long-term ventilation to help keep them safe. So in Ontario, we're fortunate to have the ventilator equipment pool. They are a central distributor of all ventilators in the province, and we were able to secure funds with their through their annual budget to support a COVID-limited provincial rollout of an eHealth platform. So the LIVE project, essentially what we're aiming to do is provide the A Touch Away app to children and adults using long-term ventilation at home in Ontario during COVID-19. The app is being used to essentially support intensive virtual case management with the goal of keeping these children and adults out of acute care. Patients will download the app on their own devices, and a subset will be given a tablet to use the app if they don't have a device, they don't have internet, or their device is not compatible with the app. And I'm really excited to say that we're really partnering with all of these hospitals that you can see there on this provincial project. So in terms of the eHealth platform, what can you do with it? What does it offer? So we'll talk about these in detail, but it's a way to establish a connection within the circle of care for the patient and family, so everybody can securely connect together, whether that's via secure messaging, via telephone calls, via three-way video conferencing. It's also an opportunity to have a living virtual care plan that can be updated and edited and created by the patient and family, and also by the healthcare team. It's an opportunity for us to develop custom workflows so we can check in with patients on a regular basis and make sure they're doing okay and identify any issues early. It's a way for us to be able to do ventilator downloads remotely, which is really important when caring for children and adults who use ventilation. And it's really a helpful suppository of information for educational resources, and it's also a way for us to send patient reminders. Secure communication. So if you were to log into your app, so this is me logging in here, you have a section where you have contacts, and then you have a section where you have patients. So patients and healthcare providers in the circle of care can communicate via secure messaging, phone, or three-way video calling just at the touch of a button. And then healthcare providers that are added as contacts for each other can also communicate to each other independent of the patient as needed. And you can see this. So this is my section where these are my contacts in white. And then in the green, this is my list of all of my managed patients. And these are all just test patients because we haven't launched just yet. And we'll talk shortly about why some patients are green and why others are yellow and red. So if you were to go ahead and make a telephone call to your patient, you're then able to minimize the telephone call. So you can invite a third person to join your call, but you're able to minimize the call so that you can go ahead and work on the app or check the health record, whatever you need to do during the telephone call. So when you click on your patient that's listed, you come up to the patient dashboard. And just in the interest of time, we're going to focus on a couple of things as we go through. So this is our demo patient. Your real patient would have a nice picture of themselves there. And then we would have an icon for workflows and resources, which we'll talk about. And then you're going to see a whole host of group forms. So the group forms are really what make up the virtual care plan. So this is a virtual care plan that's developed by and accessible to the patient, family, and the nominated circle of care providers. And it provides a pretty comprehensive summary of the medical diagnoses, the respiratory technology settings, the ventilator settings, any special considerations. And there's also an opportunity, many children and adults have an action plan for who to call for what and when. And there's also an opportunity to be able to upload that PDF in this action plan. And so if you think about it, each of these little icons that you can see here in the image on the right, you can click on those and it'll open up into a set of forms where you can enter information. So for example, if I clicked on the respiratory technology form, it's going to open up to a series of respiratory technologies, and you can enter as many as you need because many of our patients are using almost all of these things. And then as you click on it, it'll provide a drop-down menu that'll ask you relevant questions that pertain to it. So someone who's on invasive ventilation, so that's ventilation via a tracheostomy, they can be prompted in terms of how that invasive ventilation is used, how many machines do they have, who applies and removes the vent, what are the details about the tracheostomy in terms of the brand and the type and the size, do they have a cuff or not, and then what are the different adjuncts that they use on the tracheostomy during the daytime, as well as important information like when was the trach inserted and when was the date of the last trach upside size. And then on the separate icon for the ventilation settings, you would click on that icon, and then using branch logic, you'd be able to fill in all of the relevant settings. So for those of us who care for these patients, and those of you who do as well, you know that you often have to dig through the chart to find this information. And I think you can appreciate how helpful it would be for the patients and families to have this information at their fingertips, but also as clinicians to have it. So another aspect of this eHealth platform is really to try and identify patients before they need to go to acute care. And although, of course, this is a fragile population, definitely, there's many ER visits that cannot be prevented. But the idea is, or the thinking is if we sent out a weekly and a monthly questionnaire that specifically asked patients how they're feeling, would we be able to recognize problems early and intervene early and prevent acute care hospital needs? So, for example, in this project, we're sending out a weekly monitoring of symptoms. It has 8 questions, one of which you can see here. So it asks, in the past week, are you or your child experiencing any of the following symptoms, which would include a new cough or worsening of your normal cough, new trouble breathing or worsening of your baseline shortness of breath, changes in the color or amount of secretions, is there a fever, is there a headache, is there a new sore throat, or is there none of the above? And essentially, based on how the patient answers these questions, they get an overall status. And this happens sort of behind the scenes in the app. So the patient will be coded as either green, meaning everything is great, yellow, meaning there's a couple of things that are concerning, or red. And so if your patient has completed the workflow and they're coded as red, you are going to get a notification that your patient is red, and they will be coded red when you look at your patient list. Then when you go and you actually click on your patient, you're going to get a patient alert, and it's going to say that patient is red, clinical team has to respond in less than 48 hours to prompt a reach out. And what you can do is, because the patients are completing these workflows, these questionnaires, as the healthcare provider, you can pull up that workflow. You could have a look and see how the patient responded, so you have a sense of what's going on before you go out and call your families. And similarly, patients will be coded as yellow. The patient will just appear yellow instead of red. You'll get a prompt saying your patient's yellow, and you have to respond within less than 5 business days. These have sort of been, the duration of time to respond has been developed sort of arbitrarily with the clinicians across all the ventilation teams with regards to what is sort of a response time that they're able to cope with and manage based on their current workflows and processes. So ventilator data downloads. So ventilators, when we see children and adults in clinic who use ventilation, we always make them lug their ventilators to clinic so we can download the data, and that ventilator download data is really helpful for us to understand how effective the ventilation is for the patient. And it helps us understand what things need to be changed when. Again, with an enter COVID-19, that's put a wrench in our ability to do downloads in clinic, because now we've converted, as you've heard from Dr. Lim, exclusively to virtual visits, almost in its entirety. So how do we overcome this challenge? So there are modules that we can get and that we're having for this project that can connect to the ventilators at home. Using that, you can live stream the ventilator data, and it can be summarized and produced in a report. And so through our partnership with the Ventilator Equipment Pool, we are able to get a report for our patients ad hoc as needed, and this report will be uploaded into the app directly for us to be able to review when we're troubleshooting with our patients or when we're having our planned virtual visits. Okay, lastly, just a quick mention about educational resources. So we ask a lot of our patients and their families for all of the care needs. And usually when they start getting trained, they get a huge binder of information and web links. So it's nice to have a repository of information for families that they can use for refreshers. And also it's helpful to have this sort of at their fingertips so that if one of the clinicians is calling to review troubles with granulomas, and they can click on a resource that's about tracheostomy tube granulomas. And so we've set up this resource library of PDF documents and video links that are uploaded into the app. When the patient's getting onboarded, we can customize that library for the patients. So based on what type of ventilator they have, based on if they're adult or pediatric. And then it can be used by clinicians when reviewing with the patients and their families different issues that may arise. So this is just a screenshot of some of the educational resources that are largely based on types of ventilators, oximeters, and respiratory equipment. And if you want to click on one just to show you what it looks like, it would pull up a document, and this one is for the A40 ventilator, and it happens to be in French. So this is how you would clean your A40 ventilator if you needed a refresher on how to do so. So with that, I would like to end and say a huge thank you to a team, because I'm just one person who's speaking on behalf of this incredible team of people who have been working so hard on this project for the past 4 weeks. So it's a real privilege to be part of this team. I want to acknowledge my co-director of this project, Regina Pizzuti, who is a manager of the ventilator equipment pool. And I just want to show, this is sort of an image of all of us having our Zoom meeting earlier on this morning to talk about the project. So we are really excited, hope to have answers shortly in terms of how things are going, and our planned launch date is actually early next week. Thank you.
Just 1 second while we transfer speakers.
Sure. Hi, everyone. It's Carolyn. And so I'm going to say good morning because we're still in the morning here in Vancouver. And I'm going to just talk today about what our clinical experience has been with basically getting up and running with the virtual health clinic fast during COVID. So it's sort of the lived experience of what we've been doing for the past 8 weeks, essentially. So we have a little bit of experience prior to COVID-19 with some telehealth, so televideo conferencing from set locations, usually in child development centers or hospitals, usually in a boardroom. And our tone management team and some of the other teams here, we did do telehealth appointments. So in 2018, we did around 13. 2019, we did about 6. So we had a little bit of experience doing it, but it wasn't a primary part of our practice at that time. We've been trying to use it more, but we did do a lot of phone consults and follow-ups, and they would be regular scheduled or booked appointments. So we would do a fair number of those, and so you can see we did about 16 or so in the 8 to 10 weeks of the start of 2020. So a couple of weeks for sure. And those are regular scheduled appointments. That's not, that doesn't include just ad hoc phone follow-ups from families or when something's coming up. So then on March 12th in BC is when everything changed. And so starting on March 16th, we started delivering care in a very different way. So sitting down with our team here, our goal was essentially to run regular clinics, but doing virtual appointments. So we had Skype for Business. We had some FaceTime. We have iPads and things like that we use with some of our therapists out in the community, and Zoom, and our virtual health office and our clinical innovations team here were really great at getting us up and running on Zoom quite quickly and making sure that we had the Zoom healthcare so that we could avoid Zoom bombing and things along those lines. So when when we were doing the appointments, our parents and our caregivers, they were provided with the option of how they'd prefer for the appointment to be booked. So whether they wanted phone or whether they wanted Zoom or Skype, so that they had some control over how it could occur. So since the March the 16th, we've had 31 scheduled appointments booked via the Zoom. Issues with the FaceTime are you can't pre-book a FaceTime appointment, and not all families have either iPhones or iPads, so it wasn't as accessible to everybody. As well, Zoom is easier for families to access than Skype for Business. We had some issues with that. And the appointments are lasting about 60 minutes each. Typical appointments are 60 to 90 minutes for one of our in-person clinic appointments, but without the physical assessment, we required less time, but still need up to the 60 minutes because of the extra questions and time needed for clarification. Often in virtual health, things just seem to be a little bit different, a little bit more stilted, as we all know from our Zoom conversations that we're having. So this is kind of the setup that we've been using for our Zoom conferencing. You'll see that we use a conference or boardroom, so we can have a couple of us in the room at the same time, being across the large boardroom table. So we've got the physical distancing. We've started having our residents and learners in the room with us, so we can have 2 to 3 for sure, and probably 4 people quite safely physically distancing in the room. The reason that we're going for this model instead of doing individual from individual clinic spaces or individual office spaces, it just enhances the communication. I think it's easier for the family. They see us together. And again, it's just sort of a smoother flow in terms of communicating and planning with the care. So we are using an iPad right now. It's mirrored to an Apple TV that then is displayed on our large screen there at the side. So we get a really big, good view of the family. It's not a small computer screen. So when we're getting the families to do things, it's really working well. And you'll see in the middle of the table, we have our conference phone that's set up just in case of issues. That's been a primary problem. And then we have telephones. So again, we've had 51 scheduled appointments booked via the telephone. We use the conference phone for the best quality sound. We do have speaker phones in our offices, but they do sometimes make things difficult. So we prefer to use the conference phone to get the best quality sound, and it seems to be good feedback from families and caregivers. So challenges that we've had, which I think that everybody had, certainly it seems better in the last couple of weeks than initially, but patchy or slow internet. So again, we're seeing kids from around the province. So we've got a huge geographic area, and not all of the areas have high-speed internet. And families who don't have high-speed internet, they may or may not have unlimited data if they're using their phone or something along those lines. Some of the telecoms have enhanced the data just in terms of opening it up and saying that there's unlimited data now for this period of time, as well as have increased the speed so that people are getting better sound or better video and not as many issues with the video. Things that are problematic with families is sometimes we haven't been able to fix the problems with the Zoom or the video, so we just revert to the conference phone about that time. And we have still had a couple of people who forgot about the appointments or have not shown up for them. So, but not very many actually. It's everybody's at home, so for the most part we've had just 1 or 2 in that regard. So general issues, as we all know, is that they can't get the link, isn't working, or they don't have the app downloaded on their computer or tablet or equivalent. So they have to go in through the browser. Sometimes we've had to do a phone call just to help them get linked up with that, or another family member has helped walk them through. And often we start, and they're online, but you can't see or hear, or you can see them or not hear them. So again, just trying to work through the gaps to start with. And this goes to the same with professionals. So it was, new systems to all of us. So we're getting used to setting up the equipment and the processes that are needed to get everything organized and going. it's a new process for everybody. So learning how to do it, how to be the troubleshooter, and how to support the families to do it has been a real learning experience for everybody. And then with our clerks, so they're new to booking the appointments in this way. So it's adding extra steps for them in terms of how to book the process, making sure that we have consent from the families. We need the families' email addresses so that we can send them the links to the appointments as well. So it's just a different way of doing things, and we've had to learn the new systems quite quickly. So problems with it. So you can't do specific assessments, i.e. in the tone management clinic, we can't do a feel tone, so we don't know about the modified Ashworth scale or doing a Tardieu assessment. So you can't improvise as much. So it's a little bit harder to try something different if the child's are unhappy or upset. It's really just on the parent or the caregiver who's with them to try to figure that out. So, things don't always go as smoothly. One of the other key issues we've been having is the fact that, a large part of our population have English as a second language. So trying to link in interpreters has been a bit of a challenge. So it's very easy to do with a phone call because our provincial language services, we contact the interpreter, and then the interpreter connects via the conference call to the family. So that's much smoother. But with the virtual Zoom or video calls, it's much more challenging in that regard. So we'll have to figure that out down the road. So the benefits that we've been seeing are the fact that we're able to see and hear the families, and that we've been actually able to ask the family and caregivers to perform specific activities so we can get them to, do range of motion, and we can see the difficulty they have. We've asked them to put on splints and see how well that goes for them. Families can demonstrate the dorsiflexion and plantarflexion for us, and it's been really good, and see them walking up and down the hall in their home to look at their gait and things along those lines. So there's been some real benefits being able to see them in their own environment as well. I think it's the kids are, content and happy and have their regular things around them. I think that for the families, just during this really challenging and unique time, that can be quite scary, what's going on, and the fact that they don't have to come to the hospital or a clinic is great for them. So, but they can still be connected with us and keep the regular appointments. And a lot of families are really appreciating the contact and ongoing care that they're getting. So the other benefit that we really have heard from families is that they don't have to drive or fly for significant distances. So, families whose kids can't get on a plane because they don't tolerate it well. We've got families who drive for 14 or 16 hours to come down to see us. So the fact that they don't have to do that, that's a 3 or 5 day trip at the least for them. Takes a lot of time off work, lots of costs involved. The fact that they don't have to do that has been fantastic, and I think is something that for sure we have to continue doing, because if we can reduce even these kinds of trips for them by 50%, then I think that that's a monumental improvement to their overall quality of life and challenges that, reducing that challenge that they have already as caregivers. So I think that one of the key things is we have to ensure that we have consent from the families. That it's a novel method of service provision, and so I think that making sure that they're comfortable with it and that they know they have different options is important. One of those options is to wait, and so that's okay. We need to ensure that the family has all the technology that's required if we're going to do it. So how can we as a, is there a way that we can loan technology out for an appointment or something along those lines? And how would that work? And do they have adequate data to be able to support the system at the time? And comfort and competence with the technology. I think that for the professionals, for sure, getting it set up, knowing that you've done the right job, being able to support families through it. So we need to make sure that we have a little bit of time to set up to start, and that we know what we're doing so that we can support families. And so it's going to be a learning experience experience for all of us and keep going. And we have to be okay with failure, challenges. It's going to happen. It's new, and always have a backup available, which is the conference phone for us. And that's worked out really well. And families have been really fine with it for we haven't had any issues or anybody getting really upset with it. So many families have expressed that they hope it's going to be an ongoing method of service delivery. I think it's going to be a really strong piece of our ongoing practice, especially for screening and for follow-up. I think, definitely still need to see families, but if we can reduce it, that's fantastic. So really, it's been an imperfect integration, but I think everybody's been really willing to try, and that's been just amazing to see. And I think that we've had so many families talk about how the fact that they just don't feel so isolated because they know that we're there and that we can reach out to them. So it's been really an amazing opportunity. Okay.
We have a number of questions here. I will, there's a few that are quite similar, so I'll try and summarize a few here. The algorithm that was created by the family, and this relates to Audrey's presentation, is that available? Because this person says this is exactly the kind of tool most of us need.
Yes, the algorithm is actually from the States on the Children with Medical Complexity website, and it's available. So it was an algorithm that this family found on their website.
Wonderful, thank you. We perhaps can put a link to that website on in the chat box or on the Knowledge Exchange Network when the recording is available.
Sure, I'll do that.
How do you see care provided in schools to children with medical complexity, and how do you see that changing? Anyone?
In terms of,
I mean,
related to COVID, I think.
Yeah, I think that is really a big black box question, is in terms of what is school. I mean, I think for the most part, the school year is almost at an end, and I think that it's pretty clear that at least in Ontario, that likely in-person school is not going to be in the cards for the rest of this school year. The question is going to be what school is going to look like and how it's going to be rolled out in September. I think there's a couple of different hypotheses, such that, different children may have to go to school on different days. They're going to have to relook at, gathering in areas, and things like recess and playgrounds are going to have to be reconsidered. So I think, the truth is, your guess is probably as good as mine, because I think we just don't know what the future holds, and what things are going to look like, come the start of the next school year.
Thank you. That appears to be an answer to a lot of questions lately. Another question is, if any of your patients with tracheostomies use inline suctioning, has anyone requested the use of the inline suctioning to protect home care nurses and providers during the pandemic, given that it's an aerosol generating medical procedure?
It's an excellent point, because especially when you're deep suctioning and you're breaking the circuit, there is a significant increase in the aerosol generation of respiratory particles with regular suctioning as opposed to inline suctioning. One of the protocols that we've put in place is for our trach vent patients who are coming to the emerge or for direct admissions to hospital in the times of COVID, is that they're all presumed to have COVID until proven otherwise. And so we are switching patients who are not on inline suctioning when they're in hospital to inline suctioning until their COVID swab comes back. And for aerosol generating procedures, healthcare workers are still wearing enhanced droplet precautions with N95s. The trouble is that there's not clear guidelines yet in terms from home care. So I think that we, from a provincial perspective, have been working to try and add some clarity to what's happening. I think I think that enhanced droplet precautions for home care nurses caring for children with tracheostomies and ventilators makes a lot of sense. I think the rate limiting step is awareness of that, and also availability of PPE. So I think there's a lot of work that's being done in our center by Dr. Julia Orkin and also Krista Kilty and myself to try and reach out to our LIN partners to sort of explore some of this and make a clear plan for these children. But I think the challenge is inline suctioning is quite expensive. And I think that is a potential rate limiting step in the home for all patients.
Thank you. There's a number of questions related to the live program. Is it delivered in partnership with the Ontario Ventilation Pool? Is it an Ontario-wide initiative or restricted to a specific region?
Excellent question. So no, it's an Ontario-wide initiative. The ventilator equipment pool in Ontario is funding the project. So patients are going to be called and informed through the ventilator equipment pool, and it's being done in partnership with all of those different institutions.
And does it tie into connected care at all?
That's an excellent question. So the live program per se currently is really geared at patients and family caregivers and their healthcare providers. The connected care program in terms of the outreach is geared towards the home care nurses who are able to call the connected care program at sick kids for support around any kind of medical technology. So in some ways there's potential overlap, but they're not intimately connected, no.
Okay. Is the app available to anyone, and how can parents ask to be connected with it?
So we are at this point, we are working so each of the clinical programs that's involved. So I think first and foremost, this is not a tested program. We are rolling this out clinically because we think it will help. We do not have any evidence in this patient population that is going to improve outcomes. Just full disclosure, I need to say that. I think secondly, the approach that we've taken is that we are working with each of the ventilator programs to prioritize patients who are considered to be the most fragile, and those are the patients who are going to be prioritized to start the program first.
Thank you. Is the app, the home ventilation app, accessible also to home care providers? And is it compatible with any EMR systems that are being used in the inpatient settings?
Wow, all excellent questions. So the first is it EMR compatible? So it has the potential to become EMR compatible, but just in terms of trying to roll this out in a timely way, at present, it's not going to be compatible with the EMR. There's no EMR integration as part of the project inherently. That's the first thing. The second thing is in terms of home care providers. Yes, absolutely. This is a really important group of people that need to be connected within the circle of care. We are working first to get all of the privacy security contracts in place between the vent pool and the hospitals. Once that's done, then we are going to be going to the LIN and various other community providers to try to sequentially roll them out to really bring in those home care providers to the circle of care as well, to unite everyone together around the care of the patient.
Oh, wonderful.
That will take time.
We've noticed during COVID that home care, the planning within home care has been separate and siloed from the planning within healthcare institutions. So it's good that you're thinking ahead to that. One comment related to the use of your stoplight approach, the red, green, yellow. And this comment relates to staff that are colorblind, and it may be a barrier, the use of those particular colors, because red and green can often look the same. Is that something you've come across or had to address?
That is actually an excellent point. I have not thought about it and not come across that. But that's an excellent suggestion, and perhaps we should change our color coding to avoid that. So thank you very much for that comment.
And this team at Advocate Children's in Chicago area have been doing telemedicine for the last year or so and have just increased, of course, as a result of COVID. They love the ventilator app. They had one of their BiPAP dependent patients with muscular dystrophy die of COVID on ECMO, a young person. What are your thoughts on your support for home care for COVID in your patients? And they mentioned that all of their patients have a sick plan, but with the acute decomposition noted through COVID, they're no longer comfortable doing sick plans for home care. What are your thoughts on sick planning and home care support for COVID patients?
So, and on Audrey, you can jump in here as well. So, in terms of sick planning for COVID, I think this is something that we're all trying to manage across, whether you're a pediatrician or a home care nurse or a hospital-based clinician. I mean, ultimately, what we want to do is keep these patients safe in their homes. We also are trying to be very mindful that we don't want to keep them in the home too long, because we're hearing reports about sort of untoward events happening because patients are seeking medical care in a delayed way because of the fear of COVID. So I think the first and foremost thing is there needs to be good communication between the patient and the family and the healthcare team, whether that's your primary care provider, your ventilation team, your complex care pediatrician. I think we all need to be in close contact with each other. I think one component of the sick care plan in and of itself is just in terms of what to expect when children, especially who are using respiratory technology, are coming into hospital, because we are making a lot of changes in terms of recommendations to the types of inline suctioning, ventilator circuits, ventilators, BiPAP masks that need to be put in place because these are aerosol generating procedures. So that's, I think, one conversation that needs to be had. The second thing is, again, balancing keeping patients at home with, to avoid COVID, with not having them stay at home too long to sort of run into trouble. So I think, the reason that we sort of have decided to sort of take our live program out of the research and try to bring it to clinical care is to sort of help get us enough information to try our best to be able to support patients intensively at home in a safe way, because it's important that we have a lot of different aspects of information, including objective ventilator data, to help us do that. But again, like I said, we're embarking on some uncharted territory, full disclosure on that, so we have to see how it goes.
Wonderful. Thank you. And our last question, I think, is what supports have been helpful for the mental health of patients and caregivers in your population?
I can speak for MAC. It has been an area that we are definitely trying to help, knowing that pre-COVID, there's already an increased anxiety and mental health concerns with our population, and even more so now. I think the resources needs to, or the hospital needs to relook at the resources to allocate more help in this area, especially with social work and complex care teams, as well as the expertise to know how to help these families. And as we prepare for, the launch of our peer support or parent support group, we're not sure which one is more appropriate yet. Gathering the needs assessment that we're doing right now really helps us to know what to do, how to strategize, and what roles and what expertise is needed to deal with situations during COVID as well as after COVID, because these situations probably will not go away, and we need a structure in place to handle these situations and to help our families. So I don't have a good answer for you right now for our complex care team, but we're working on it.
Thank you. Last question, Dr. Amin, what virtual platform are you using?
So for the live program, our eHealth partner is the app is called A Touch Away, and the company is called Atonics.
Thank you. Want to thank you all for sharing your time, your knowledge, and your expertise with us. Thank you, Audrey, Reshma, and Carolyn. Today's Children's Healthcare Canada hosts our Spark live webinars every Wednesday at 11 a.m. Eastern. However, during this COVID pandemic, we are offering special editions of some of our knowledge sharing opportunities. These may fall outside of our typical webinar time slots. To stay up to date on all of our activities and events, please sign up for our Children's Healthcare Canada Spark newsletter if you have not already done so. It's always great if you can watch live, as your questions, and as we could see today, and comments really enrich the discussion. But if you can't watch live, the recordings of these sessions are made available after the fact on our Knowledge Exchange Network. Next week, we're pleased to bring you 2 COVID-related webinars. On Wednesday, May 20th at 11 a.m. Eastern, we have COVID-19, PPE, and safety, evidence, decision-making, and action. And on Thursday, May 21st at 12 Eastern, we have COVID and kids, what we know and what we don't. So thanks again for joining us today. Thanks for Children's Healthcare Canada members, Sunny Hill Health Centre for Children, Thick Kids, and McMaster Children's Hospital for supporting our webinar program. And hopefully we will see many of you back here next week. Bye-bye, everyone.